Obsessive compulsive disorder. Introduction. Jenny described the role of incompleteness in OCD patients as, as well as symptoms such as tics. Early 20th century, Freud's theories on the role of the unconscious in obsessive compulsive symptoms were influential on spectrum of symptoms ranging from obsessive compulsive personality traits, obsessive compulsive neurosis, and obsessive compulsive psychosis. Middle of the 20th century, case reports indicates that the serotonergic TCA clomipramine was useful in OCD. RCT confirmed the efficacy of clomipramine and gave the impetus to a serotonin hypothesis of OCD. Over time, dopaminergic agents and neurosurgical interventions were also developed for treatment of refractory OCD. The finding that clomipramine was more effective than desipramine, a noradrenergic tricyclic in OCD as well as in range of other conditions characterized by intrusive thoughts or repetitive behaviors, help consolidate the notion of the obsessive compulsive spectrum of disorder. DSM-3 defines obsessions and compulsions. DSM-4 compulsions can be mental acts. DSM-5 OCD shifted to new chapter on OCRD, insight specifiers, absent insights, term impulsive replaced with urge. Obsessions can cause anxiety in most individuals, not all. ICD-10 doesn't include the notion that obsession gives rise to compulsions. ICD-11 obsessions lead to anxiety or distress, and compulsions are undertaken to reduce these negative emotions. New chapter on OCRDs specifies absent insight like DSM-5, includes few disorders like tic disorders, olfactory reference disorder, hypochondriasis. Patients with Waterlington. Patients with BDD are preoccupied with flawed appearances. Those with olfactory reference disorder are preoccupied with smelling bad, and with both groups displaying repetitive mental acts and behaviors in response to these concerns. ICD-10 recognize as individuals' own thoughts or impulses, at least one thought or act resisted unsuccessfully, even though others may be present which the sufferer no longer resists. Thought of carrying out the act must not be pleasurable. Thoughts, image, or impulses must be unpleasantly repetitive. Hallmark of OCD, interfere with functioning, cause significant distress, and or time consuming. Individuals may have multiple obsessions and compulsions over time. Onset during the puberty may begin as early as the age of 2 years, infrequently begins after the age of 35 years. Predominantly obsessive thoughts or ruminations like contamination, pathological doubt, need for symmetry, aggressive, sexual, multiple obsessions, others. Predominantly compulsive acts like checking, watering, counting, need to ask, or confess, hoarding, multiple compulsions, others. Mixed obsession thoughts and acts. 42.8 other obsessive compulsive disorders and F 42.9 obsessive compulsive disorder unspecified. Epidemiology. Objective to estimate the worldwide prevalence of obsessive compulsive disorder, whether women are at greater risk than men, and explore the potential moderations prevalence to explain variability to community-based epidemiology studies. Data sources. An electronic search of cycle NFO and PubMed was conducted until January 2017 without date or language restrictions using the keywords OCD, epidemiology, and prevalence. The search was supplemented by articles referenced in the obtained sources and relevant reviews. Study selection. Studies were included if they reported current period and or lifetime OCD prevalence that is diagnosed according to an interview based on DSM or ICD criteria in representative community samples of adults aged 18 years or older. A total of 4,045 studies were retrieved, with 34 studies ultimately included. Data extraction. OCD prevalence was extracted from each study alongside 9 moderators. Gender, year, response rate, region, economic status, diagnostic criteria, diagnostic interviewer, and age. Results. The overall aggregate current period and lifetime OCD prevalence estimates were 1.1%, 0.8%, and 1.3% respectively. In typical sample, women are at 1.6 times more likely to experience OCD compared to men, with lifetime prevalence rates of 1.5% in women and 1.0% in men. There is also a trend toward younger adults being more likely to experience OCD in their lifetime than older adults. All findings demonstrated moderate heterogeneity. Conclusion. Women are typically at greater risk of experiencing OCD in their lifetime than men. Etiology. OCD is familial and heritable based on efficacy of serotonin reuptake inhibitors in treating OCD. Serotonin system genes have been dominant focus in OCD candidate gene studies. The most commonly used studied candidate serotonin systems gene variants SLC64A, STR2A, STR1B, and STR2C, and their associated OCD. Serotonin transporter polymorphism 5-HTT-LPR and STR2A polymorphism RS6311 or RS6313 are most consistently associated with OCD. Genetics. Twin studies indicate that obsessive compulsive disorder is strongly influenced by addictive genetic factors. A total of 230 polymorphisms from 113 genetic association studies were identified. OCD was associated with serotonin-related polymorphism 5-HTT, LPR, and STR2A, and polymorphisms involved in catecholamine modulation, COMT, and MAOA. Non-significant trends were identified for 2 dopamine-related polymorphisms, DAT1 and DRD3, and a glutamate-related polymorphisms, RS3087879. This study demonstrates that OCD is associated with multiple genes, with most having a modest association with OCD. Neurotransmitter. Hypersensitivity of postsynaptic 5-HT receptors constitutes the hypothesis for the underlying pathophysiology of OCD. CSF levels of serotonin metabolites, example 5-hydroxyindologlycic acid, 5-HIAA, and 5-HT metabolites that serves as the index of 5-HT turnover. In an earlier study, patients who responded to clomipramine had higher pretreatment levels of 5-HIAA than non-responders. The clinical improvement was positively correlated with decrease in the concentration of 5-HIAA in cerebrospinal fluid. Another approach to Examine peripheral measures of serotonergic and non-adrenergic function in patients with OCD. Clinical improvement during clomipramine therapy closely correlated with pre-treatment platelet serotonin concentration of monoamine oxidase activity, as well as with decrease in both measures during clomipramine administration. The plasma levels of clomipramine, a potent 5-stage reuptake inhibitor, but not the plasma levels of its primary metabolite, this methylclomipramine, which has noradrenergic properties, correlated significantly with an improvement in OCD symptoms. These findings suggest that the effects of anti-obsessive medications, clomipramine, in this study on serotonin function are pertinent to the anti-obsessional action observed. Evidence for disturbance of serotonergic system in OCD was challenges with tryptophan, M-chlorophenylpiperazine, sumatriptan, isoprione, MK212, used to evaluate whether they worsen obsessive compulsive symptoms or whether they elicit different physiological responses, thermal or norendocrine, in patients with OCD compared with controls. M-chlorophenylpiperazine and sumatriptan shows behavioral hypersensitivity and neuroendocrine hyposensitivity to the characteristic of serotonergic challenges in patients with OCD. Pinpoints the receptor subtypes involved in OCD, 5H21B but not 5H21A could be involved in OCD. Dopamine. Evidence of dopaminergic involvement in OCD comes from the OCD symptoms in basal ganglia disorders such as Tourette syndrome, Sydenham's chorea, and post-encapsular Parkinsonism. The therapeutic benefits obtained with the co-administration of dopamine blockers and SRAs is in a subset of patients with both OCD and tic disorder was also suggested a role of dopamine dysfunction. Levels of platelet sulfotransferase, an enzyme involved in the catabolism of catecholamines, providing a marker of presynaptic dopamine function, reported a decreased level of platelet 3H-imipramine binding and a parallel increase in the level of sulfotransferase activity in OCD compared with controls. This provides further support for the hypothesis of reduced IST activity and increased dopamine transmission in OCD. Neuroanatomy. Studies have pointed to the central structural imaging, CT and MRI, CT or MRI, functional imaging, PET, fMRI, SPECT, MRS, DTI. Studies have pointed to the central role of CSTC circuits in the pathophysiology of OCD for at least the past 20 to 30 years. Regional hyperactivity during symptom provocation. Successful treatment of OCD with medications, behavior therapy, or neurosurgery is associated with a reduction in activity in these regions. Harrison et al. 2009 tested the strength of functional connectivity of four striatal seed regions of interest: dorsal caudate nucleus, ventral caudate nucleus or nucleus accumbens, dorsal putamen, and ventral putamen, with remaining brain areas, and found abnormal and heightened level functional activity of ventrolimbic corticostriatal regions in patients with OCD. Greenberg et al. 2010. Abnormalities in this circuit involves OFC and ACC, the striatum and medial thalamus. Functional neuroimaging studies have consistently documented hyperactivity in CSTC circuits when comparing OCD subjects in controls. Millard and Rouse in 2012 have shed new light on behavioral control issues such as processing reward, negative affect, and fear and anxiety. Hyperactivity in the 1L-OFC mediates obsessions. Hypoactivity in the MOFC related to the inability to extinguish the recall, resulting in compulsions and the inability to inhibit the compulsions. 2. Dorsal anterior cingulate cortex in error processing and fear expression. 3. Amygdalocortical circuitry in the expression and regulation of fear. Harrison et al. In 2013 distinct anatomical relationship between the severity of symptom dimensions and striatal functional connectivity. Aggression symptoms moderated connectivity between the ventral striatum, amygdala, and ventromedial frontal cortex. Sexual or religious symptoms had a specific influence on the ventral striatal insular connectivity. Hoarding moderated the strength of ventral and dorsal striatal connectivity with distributed frontal regions. PET have shown increased activity, example metabolism and blood flow in frontal lobes, basal ganglia, especially the caudate cingulum of patients with OCD. Neurological procedures involving the cingulum are sometimes effective in the treatment of OCD. The MRI study reported increased TI relaxation times in the frontal cortex, a finding consistent with the location of abnormalities discovered in PET studies. CT and MRI have found bilaterally smaller chordates in patients with OCD. Psychodynamic theories, first described by Sigmund Freud, who coined the term obsessional neurosis. The disorder was thought to result from a regression from edible place to the anal phase with its characteristic ambivalence. The coexistence of hatred and love towards the same person leaves the patient paralyzed with doubt and indecision. Freud originally suggested that obsessive symptoms result from unconscious impulses of an aggressive or sexual nature. These impulses cause extreme anxiety, which is avoided by the defense mechanisms. One of the striking features of patients with OCD is the degree to which they are preoccupied with aggression or cleanliness, anal phase, either overtly in the content of the symptoms or in the underlying associations. 3. Major psychological defense mechanisms: isolation, undoing, and reaction formation. Isolation is the separation of the idea and the affect that it arouses. Undoing is quite the anxiety, is to quit the anxiety that its imminent eruption into consciousness arouses. Undoing is a compulsive act performing to prevent or undo the results that the patient irrationally anticipates from a frightening obsessional thought or impulse. Reaction formation is related to the production of character traits rather than symptom formation that is characteristic of above events. The trait seems highly exaggerated and inappropriate. Example, in the switch of anger and hate into exaggerated love and dedication. Behavioral factors. According to the learning theory, obsessions can be considered conditioned stimuli. When a relatively neutral stimulus is coupled with an anxiety-provoking stimulus through conditioning, it will produce anxiety even when presented alone. In these regards, even the thought of the anxiety-provoking stimulus can cause anxiety. Similarly to Pavlov's dog, which salivated even before he actually had food. Consequently, avoidant behavior is being adopted in order to avoid the anxiety-provoking stimulus and any other stimuli which remain it. The compulsions are learned as a way to reduce anxiety. Once producing relief of the anxiety, the relief serves as a reinforce the compulsion, which are then being repeated by the patient. Through the process of conditioning, reward and reinforcement, rituals and avoidance strategies or become fixed. Neuroimmunology. Positive link between streptococcal infection and OCD. Group A, 3 hemolytic streptococcal infection can cause rheumatic fever and approximately 10 to 30% of the patients develop sudden chorea and show obsessive compulsive symptoms. EEG indicates some commonalities between depressive disorders and OCD. Sleep EEG studies have found abnormalities similar to those in depressive disorders, such as decreased rapid eye movement latency. Neuroendocrine studies produce some analogs to depressive disorders, such as non-suppression and the dextromethorphan suppression test in about 1/3 of the patients. Decreased growth hormone secretion in clonidine infusions. Differential diagnosis. Generalized anxiety disorder. Worries in generalized anxiety disorder are about real-life concerns and they tend to be less irrational and ego-dystonic than in OCD. BDD, HD, and TTM. Excoriation disorder, stereotypic movement disorder, eating disorders, substance-related and addictive disorders, illness anxiety disorder, paraphilic disorders, disruptive, impulsive control, and conduct disorders, major depressive disorder. The ruminations of depression and preoccupations of mania are typically good congruent and ego-dystonic. In neither are symptoms neutralized by compulsions. Schizophrenia spectrum and other psychotic disorders and autism spectrum disorders. Definition. BDD characterized by persistent preoccupations about one or more perceived defects or flaws in one's appearance. The flaws appear slight or not observable to others. In response to their appearance concerns, individuals with BDD demonstrate mental acts or behaviors like comparing themselves with others, checking in the mirror, camouflaging their perceived flaws. TTM characterized pulling out of one's hair. This is not done for cosmetic reasons, but rather individuals often describe the irresistible urge to pull out their hair. SPD characterized by the recurrent skin picking resulting in skin lesions. Individuals with skin pulling attempt to decrease or stop skin picking but are unable to do so. While some picking of scabs is likely universal, in the case of SPD, there is associated clinically significant distress or impairment. Coding. HD is characterized by the persistent and profound difficulty discarding with or parting from one's possessions. This in turn leads to significant congestion, clutter, and to substantive distress or impairment. Tics are rapid, repetitive, often spasmodic, jerking, involuntary movements that serve no apparent purpose. Person may try to hide the tic in a seemingly purposive movement, and the movement may ultimately be shaped into vandalism. Obsessive compulsive symptoms, as well as attention deficit symptoms, are also common in Tourette syndrome. Example of tics: motor, simple like eye blinking, nose twitching, shoulder shrugging, sustained eye closure, tensing abdominal or limb muscles. Complex, touching objects or self, hitting or kicking, hand gestures, throwing, squatting or jumping. Vocal, simple ones are throat clearing, coughing, sniffing, blowing, barking. The complex ones are syllables or words, phrases, swearing, repeating one's or others' words, change in the rate, rhythm, and volume of speech. Hale-Brown Obsessive Compulsive Scale. Clinician administered severity scale 10 items, 5 each for obsessions and compulsions, rated from 0 to 4. 5 dimensions, time spent, interference, distress, resistance, and control. Total score above 15 is indicative of clinical OCD. Brown Assessment of Belief Scale. degree of conviction and insight patients have connecting their beliefs. The BABS is based on insight, good insight to poor insight, overwhelmed ideas, not no insight, that is delusional thinking. 7 items. The first 6 items are added to obtain the total BAS score. National Institute of Mental Health and Global Obsessive Compulsive Rating Scale. 1 to 3 is normal, 4 to 6 subclinical, 7 to 9 clinical OCD, 10 to 12 severe OCD, 13 to 15 very severe OCD. Comprehensive psychopathological rating scale. OCD subscales has 8 items: rituals, inattention, compulsive thoughts, concentration difficulties, worry over trifles, sadness, lassitude, indecision. Efficient a tool as the YBOCS for assessing OCD symptom severity. Lighten obsessional inventory. LY has 69 yes or no questions, screening purpose. The vascular obsessive compulsive inventory. Vancouver obsessional compulsive inventory has total 55 items, 6 subscales, contaminations, checking, obsession, hoarding, just right, and indecisiveness. Obsession compulsive inventory has 32 items in 7 subscales, measuring distress cost, cutoff score of 40 and above, high internal consistency, and high retest reliability. Rating scales developed to measure the severity of component symptoms or compulsive syndrome. Many compulsive hoarders have poor insight into their condition and self-report and clinician administrator scales are used. Saving inventory revised SIR. Self-report 23-item questionnaire validated reliable. 3-factor subscales like 1 difficulty discovering, number 2 excessive clutter, 3 compulsive acquisition. Maximum score of 92, minimum score of 36, cutoff to meet the criteria for HD, used to distinguish hoarders from non-hoarders. UCLA hoarding severity scale, clinician administrative scale, 10 items, SEMI semi-structured interview, which allows the interviewer to ask additional questions for clarification, which helps improve accuracy. Assesses the associated features of indecisiveness, perfectionism, disorganization, and procrastination, which are associated with the categorical diagnosis of HD, as well as severity and impairment, especially social impairment. Scores should reflect average occurrence of each symptom over the week prior to the assessment of review. Maximum score 40. Assess the presence or severity of components of compulsive hoarding symptom. Hoarding rating scale interview. 5-item semi-structured interview with good internal consistency and reliability. Includes difficulty discarding, difficulty using rooms due to clutter, excessive acquisition, emotional distress, and functional impairment. Maximum score 20, minimum score 14, cutoff score between compulsive hoarding and non-hoarders. Defined as a severity instrument and not a diagnostic instrument, since it does not ask the specific reason for hoarding and difficulty discarding.